So in previous two lectures, we had discussed about the various risk factors of atherosclerosis as well as the pathogenesis of atherosclerosis. In this lecture, we are going to cover the morphology as well as the various complications that can arise because of atherosclerotic lesions. Starting with morphology of atherosclerosis. Atherosclerotic lesions, these are divided into early lesions or fatty streaks and advanced or well-developed lesions which are called as atherosclerotic plaques, atheromatous plaques, or simply atheromas. Starting with fatty streaks, these are the earliest lesions of atherosclerosis, and these lesions, these are composed only of lipid-filled foamy macrophages. So we will divide these fatty streaks as well as atherosclerotic plaques into their naked eye appearance as well as how these lesions appear under the microscope. So starting with gross appearance of fatty streaks, these lesions, they appear as multiple minute yellow spots on the intima of blood vessels, and as they advance they coalesce into elongated streaks of 1 centimeter or more. What makes these lesions different from atherosclerotic plaques is that these lesions, these are not significantly raised as compared to atherosclerotic plaques, which are significantly raised and protrude into the vessel lumen. Distribution and evolution. These lesions, it has been observed that they start appearing as early as the age of 1 year, and by 10 years almost all children will have some number of fatty streaks. So although they may evolve into plaques, however, not all fatty streaks they evolve into atheromatous plaques. However, they have been found in the same location as atheromas. So there are confounding factors. So relationship between the fatty streaks and atherosclerotic plaques, it is unclear. Then coming on to atherosclerotic plaques. Grossly, these lesions, these are elevated as compared to fatty streaks which are not elevated. These lesions, these are elevated and these are about 0.3 to 1.5 centimeter yellow colored to whitish plaques, and these can be larger as they evolve in size. Surface of these lesions will be yellowish to white colored, and if it becomes complicated by secondary events, then it can also be brownish to reddish brown in color. Then cut surface will have a yellow grumous core which will be composed of lipids. So lipids will give it this yellowish color which will be located in the center, and towards the innermost part of these lesions it will have a whitish cap of fibrous tissue. This photograph shows the gross appearance of fatty streaks, which are highlighted here by a red colored box as well as black colored arrows. These are appearing as flat streaks of yellow colors on the surface of intima of blood vessels. This photomicrograph shows the appearance of fatty streaks microscopically. You can see that these are pointed out by arrows, these bubbly cells. These are foamy macrophages. This picture shows the gross appearance of an atheromatous plaque. These are again pointed out by arrows, which are raised plaque-like structures which are yellowish white in color, and these ulcerated brownish areas, these are also seen. These are ruptured or complicated plaques. Again, this photograph shows the gross appearance of complicated atheromatous plaques. As you can see, there are these multiple cauliflower-like growths which are dark brown in color. So these are basically complicated atheromatous plaques, and in the background we can also see these elevated yellowish areas which are uncomplicated atheromatous plaques. Coming on to distribution of atheromatous lesions, these lesions involve the vessels eccentrically, that is, they do not involve the whole circumference of the vessel. Sites of predilection are abdominal aorta followed by thoracic aorta. So these two are the most common sites of involvement of vessels by atheromatous lesions. Other sites in descending order are lower abdominal aorta, the coronaries, popliteal arteries, internal carotid artery, and the vessels of circle of Willis. Vessels of upper extremities, mesenteric vessels, renal arteries, these are usually spared except at their ostia. As we had earlier discussed, that atheromatous lesions, they tend to occur at the sites of disturbed blood flow. So there is non-random distribution of these lesions rather than random distribution of these lesions. So there are specific sites of predilection of presence of these lesions. Amongst them, the most common sites are abdominal aorta followed by thoracic aorta. Coming on to microscopy. Microscopy of atheromatous plaques, it can be divided depending upon their components or depending upon the various zones of the atheromatous lesions. So what are the various cell components or components of these lesions? These are cells, or these can be extracellular matrix or lipids. So what are the various cells that can be seen in atheromatous lesions? These are smooth muscle cells, macrophages, and T cells. In extracellular matrix, we have collagen, elastic fibers, and proteoglycans. And in lipids, we have intracellular as well as extracellular lipid. Intracellular lipid will be in foam cells as well as in smooth muscle cells. Then atheromatous plaques can also be divided depending upon the various zones of these atheromatous lesions. These are divided into cap, shoulder, and core. This cap is the surface of the atheromatous plaque. Shoulder is the area which is just below and to the sides of the cap, where it is attached to the vessel wall, and core is the center of the plaque where these lipid debris and foamy macrophages, they will be there. So this is how these lesions, these atheromatous plaques, they can be divided depending upon various cell constituents and depending upon their various zones of these lesions. What is important is that the cellular composition of these different zones of atheromatous plaques, that is cap, shoulder, and core, these are different. So as we have discussed that the cell composition of different zones or areas of atheromatous plaques is different. So what are the various cells that comprise these different zones? So the cells of cap are smooth muscle cells and relatively dense collagen. These constitute the cap region of atheromatous plaques. Shoulder is comprised of macrophages, T cells, and smooth muscle cells, whereas in the core or the centralmost area of an atheromatous plaque is comprising of lipids in the form of cholesterol crystals. They can be debris from dead cells, they can be foam cells, there will be fibrin, variably organized thrombi can be there, and at times there will be superimposed secondary changes on the plaque, which can be in the form of calcification, hemorrhage, there can be rupture of plaques, thrombosis, there can be erosion and aneurysm formation. All these, they can be observed in an atheromatous plaque. So these are the different cells which are located in different areas of an atheromatous plaque. So earlier we had seen how these atheromatous plaques, uncomplicated or complicated, look grossly. Coming on to the microscopic appearance of atheromatous plaques. This arrow with the letter L is showing the original lumen of the blood vessel, and this broad blue colored band with the letter F in the center is the fibrous cap of an atheromatous plaque, where this blue colored band is meeting with the pink circle. This area is the shoulder of the atheromatous plaque, and the whitish center with the letter C, this empty looking space is the central lipid core of the atheromatous plaque. Towards the right, again we have this arrow which is highlighting the thinned out media. Again, there is all these three common areas of the atheromatous plaque, which is the cap, shoulder, and the core is there, and this atheromatous plaque is impinging upon the media of the blood vessel, and where the arrow is there, it is completely, this media is completely thinned out. This line diagram shows a fully developed atheromatous plaque involving a vessel. This is a cut surface of a transverse section of a blood vessel. In the upper half, there is uninvolved blood vessel where if we go from inside to outside, we have intima followed by internal elastic lamina, then we have media and externally we have adventitia. If we look at the lower half of this blood vessel, we can see that the fibrous cap of atheromatous plaque, it is protruding into the lumen of the blood vessel and it is composed of smooth muscles as well as macrophages. Towards the center, we have the lipid core of this atheromatous plaque, which is composed of necrotic debris, foam cells, which are seen with their bubbly cytoplasm, and then we have these rhomboid empty spaces, which are cholesterol clefts. Also, as we can see, just beneath this atheromatous plaque's core, we have only 2 to 3 layers of smooth muscles, whereas in the uninvolved part, we have multiple layers of smooth muscles in the intima. So, intima, which is lying directly beneath the atheromatous plaque, is also thinned out. This line diagram is also showing the various zones of an atheromatous lesion. As we can see, at the top we have a single layer of endothelial cells. Below that we have fibrous cap. As we had discussed earlier also, that the cell constituents of different zones of atheromatous plaques, they are different. So as we can see, in the fibrous cap we have only macrophages, few of lymphocytes and smooth muscles. As we go towards the core of the atheromatous plaque, we can see that there is this homogeneous pink material which is necrotic debris. Then we have these rhomboid empty spaces which are cholesterol clefts, which are derived from dead cells. Then we have foamy macrophages with their bubbly cytoplasm, and directly below that we have this layer of intima, which, as we can see, that this inner core of this atheromatous plaque, it is impinging upon the media. Now that we have discussed the morphology of atherosclerosis, let's talk about complications and consequences of atherosclerosis. As large and medium-sized arteries are involved by atherosclerosis, therefore the organs that are most commonly affected by atherosclerosis are heart, brain, kidneys, and lower extremities. So, because of impaired blood supply to these different organs, there will be infarction of that particular tissue leading to certain clinical symptoms. For example, if there is infarction of myocardial tissue because of impaired blood supply to the heart, so this patient will present as a patient with heart attack. Then if there is infarction of cerebral tissue, then the patient will present as stroke. Then the patient can also present with complications of aortic aneurysm because of vessel wall weakening, or the patient can present with peripheral vascular disease, which will present as gangrene of extremities. So these are the major clinical consequences of atherosclerosis. So atherosclerosis in itself, it is not presenting, but it is impairing blood supply of different organ systems, which in turn will lead to specific organ related symptoms, and these will present clinically. So how does atherosclerosis lead to all these complications? These complications appear due to either occlusion of blood vessel lumen by the atherosclerotic plaque, or there is rupture of atherosclerotic plaque, or there is vessel wall weakening because of impinging of atherosclerotic lesion on the media of vessels, or there is stenosis of blood vessel wall because of a growing plaque. So complications related because of atherosclerosis are divided broadly into progressive lesions, which are developing over a period of time, or there are sudden changes which are called as acute plaque change. So starting with progressive lesions or atherosclerotic stenosis. So this will develop over a period of time. An atherosclerotic plaque will start maturing and increasing in size until it reaches a point where there is more than 70% of vessel lumen will be occluded, and this is called as critical stenosis. So this critical stenosis will now compromise the blood supply of the end organ, and this can present as now either bowel ischemia or sudden cardiac death, chronic ischemic heart disease, ischemic encephalopathy, and intermittent claudication. So this is a progressive lesion related because of atherosclerosis, which is stenosis of blood vessels, which can ultimately reach a point of critical stenosis and then which will lead to impaired blood supply of the end organ. Then the second type of complication is acute plaque change. Acute plaque change, the hallmark of acute plaque change is that it will be sudden development. So it will be characterized by sudden events that lead to vessel occlusion, and it will lead to local or distant ischemia. So in as opposed to these progressive lesions, acute plaque change, they will develop suddenly. So these are characterized by either of the following. Either there can be rupture or fissuring of plaque. So a plaque which was previously smaller in size, it had not reached a level of critical stenosis, it ruptures or fissures, and because of rupturing, the embolization of the thrombogenic contents of the atherosclerotic plaque, it is there, and these emboli then lodge in distant organs leading to ischemia. Then there can be sudden hemorrhage into the plaques. That will also lead to sudden increase in the size of the plaque, which was previously smaller in size. Suddenly it will enlarge in size, and that will lead to stenosis of or compromise of the blood supply to the vessel. Then there can be erosion or ulceration of plaque. So because of erosion or ulceration of the plaque, again there will be one will be that there will be formation of thrombus at the site of the atheroma, or this thrombus will now get embolized, and that can lead to distant ischemia. So both local as well as distant ischemia can be seen in acute plaque change. If it stays at the site of atheroma, then it will lead to local ischemia, and if it embolizes, then it can lead to distant ischemia. So now that we know that some plaques they can undergo acute plaque change, so now we want to discuss what are the factors that will influence the development of acute plaque change. Are all plaques susceptible for acute plaque change, or there are certain features or composition of the plaque that affects whether it will go into acute plaque change or not? So this is dependent upon composition of plaques. So some plaques will be more susceptible for acute plaque change, that is, they are more susceptible to rupture or hemorrhage or ulceration. So depending upon that whether they are more susceptible or less susceptible, they are divided into further two types. One is stable type of atheromatous plaque, and second is advanced plaque or vulnerable type of plaque. Stable plaques are also called as fibrofatty plaques. So starting with fibrofatty or stable plaques, as the name suggests, these plaques are fibrofatty, so their fibrous cap will be thicker and the central lipid core will be thin, and there will be presence of few inflammatory cells. As compared to advanced or vulnerable plaques, these have large number of foam cells in the center, and there is abundant extracellular lipid. Also, the fibrous cap which provides support to this plaque is also thinned out. So these plaques they have thinned out fibrous caps which contains few smooth muscle cells, and these plaques will also contain clusters of inflammatory cells. So fibrofatty plaques have thicker caps, thinner cores, and few inflammatory cells, whereas these vulnerable or advanced plaques they have thinner caps, more amount of foam cells and extracellular lipid, and clusters of large numbers of inflammatory cells, as well as presence of fewer smooth muscle cells. Also, the stability of plaque depends upon plaque cap elastin content. Now this elastin is an extracellular matrix. So this is synthesized by smooth muscle. So again, both of these they will influence the stability of a plaque. So this elastin is in turn dependent upon interplay of matrix metalloproteinases and tissue inhibitors of matrix metalloproteinases. As you know that matrix metalloproteinases they degrade collagen, And these matrix metalloproteinases, in turn, they are synthesized by inflammatory cells. So the plaques which have more of inflammatory cells, they will have more of matrix metalloproteinases, and therefore there will be more of degradation of collagen, leading to weakening of plaque, which will lead to a vulnerable plaque. In comparison, if there is more of tissue inhibitors of matrix metalloproteinases, which are synthesized by endothelial cells and smooth muscle cells, then the plaques will be relatively stable. So coming on to inflammation, again plaque inflammation, as we know that inflammatory cells, they synthesize matrix metalloproteinases, so they will increase collagen degradation and they will also reduce collagen synthesis, leading to weakening of plaque and leading to formation of more vulnerable plaques. So all these factors, the thickness of the cap of the erytheromatous plaque, the lipid content, the inflammatory cells, matrix metalloproteinases, tissue inhibitors of matrix metalloproteinases, elastin content, all these factors, these are internal to the erytheromatous plaque. But there are also external factors which influence the stability of plaque or acute plaque changes. So these external factors are excess emotional stress. There can be shear stress, which is created by high blood pressure. So all these also increase the mechanical stress on the plaque. So as we have seen that many heart attacks, they occur early in the morning. So these are likely to be associated with adrenergic surge, which is associated with waking up and rising. So both the factors which are internal to the erytheromatous plaque as well as the factors which are external to erytheromatous plaque, they influence the presence of acute plaque change. So what is the morphology of acute plaque change? There can be either ulceration or fissuring of plaque, which will lead to thrombus formation because the thrombogenic contents of erytheromatous plaque, they are exposed now. The endothelial integrity is disturbed, and that will lead to activation of clotting cascades and uh, attachment of platelets to the site of this ruptured erytheromatous plaque, which will lead to sudden increase in size of the plaque. Then, if the plaque is relatively vulnerable, so it can also undergo rupture, and these ruptured contents can now become embolized and lodge at distant sites, leading to atheroembolism, or there can be aneurysm. If the plaque is relatively larger in size and the underlying media has become considerably thinned out, so ultimately there will be significant vessel wall atrophy, which will lead to and outpouching, and ultimately the vessel wall will give away, so that will lead to formation of aneurysm. This diagram demonstrates the contrasting features between vulnerable plaques and stable plaque. On the left we have a vulnerable plaque which has a thinner cap, it has more of lipid content, and there are clusters of inflammatory cells. Towards the right we have a stable plaque which has a thick fibrous cap, lipid content is relatively less, and there is few of inflammatory cells. This diagram shows the evolution of a atheromatous plaque as well as the various complications that can arise because of it. So towards the extreme left, we have a normal artery which has now developed a fatty streak. As you would recall, that fatty streak has just collection of foamy macrophages. Then over a period of time, it also includes the liquefied lipid content. There is fibrous cap development and accumulation of smooth muscles, which lead to formation of a fibrofatty plaque or early or stable plaque, which has a thicker fibrous cap. There is a thinner lipid core, and there is enough amount of smooth muscle cells support as well as elastic content. Then, as this plaque matures, it becomes an advanced or vulnerable plaque which has a thinner fibrous cap. It has more of a liquefied center of lipids, and there is less support of smooth muscle cells and elastin. So, this advanced or vulnerable plaque can now undergo either progressive plaque change, which is depicted at the bottom, or it can have an acute plaque change. So if we start with the progressive plaque change, so over a period of time, this advanced or vulnerable plaque, it will go on slowly increasing in size. Ultimately, it will reach a point of critical stenosis and it will compromise the blood supply to the end organ. Or it can undergo acute plaque change where there can be either mural thrombosis, or it can become embolized and cause distal ischemia, or because of impinging upon the media it can cause vessel wall weakening leading to aneurysm and rupture. Or the plaque can rupture, or it can become eroded, or there can be hemorrhage into the plaque, or there can be mural thrombosis, or it can get embolized to distant organs. So all these can cause occlusion by thrombus, that is because of either rupture, erosion, or hemorrhage or thrombosis of the plaque. It will suddenly increase in size and compromise the blood flow to the end organ. So these all are the various complications, whether acute or progressive, that can result from an atheromatous plaque. So as you can see towards the left, we have a preclinical phase. So basically, up till the point where the blood supply is not critically compromised, these plaques, they will not become symptomatic. It is only when it reaches a point of critical stenosis or they undergo acute plaque change, only then these atheromatous plaques, they will become symptomatic and will usually present with all the complications that we had just discussed. This photomicrograph shows the transverse section of a blood vessel which is affected by an atheromatous plaque. As you can see that in A diagram, we have the lower half of the blood vessel, it is affected by an atheromatous plaque, but the lumen is still patent, which is seen as a clear space. Also, an arrow is pointing, which is pointing towards plaque rupture. So before the formation of, or before the rupture of this plaque, there was sufficient blood flow was there in this particular vessel, whereas as we go to the diagram B, at the site of that rupture which was seen in diagram a thrombus has formed now, which is completely occluding the lumen of the blood vessel. So this is an example of acute plaque change, and these symptoms will develop suddenly, as we had earlier discussed. So with this, we have completed the various risk factors, the pathogenesis, as well as morphology, along with the various complications that can arise because of atherosclerosis. In the next lecture, we will discuss about aortic aneurysm and dissection.